think you're going to be really happy that you did come out. We're delighted to have one of the leading figures in interventional cardiologists in Orange County with us tonight. Before we start, I wanted to just let's see if I have it here. Just a few. I'll give it to you later. Previews of coming attractions. And before you get out of here, I'll give it to you. But of course, atrial fibrillation is one of the most common cause of arrhythmias in the senior population. And I've had atrial fibrillation, and as I'm sure many of you also have had. And today we have with us Dr. Brian Kim, who's an interventional cardiologist at St. Jude and St. Joseph Hospital. And he's a very distinguished cardiologist, and he went to school here in Fullerton. He started out at Sunny Hills High School. Don't hold that against him. It's really good high school. Then he went to the University of California and got his bachelor's degree in Medical College of Pennsylvania in Philadelphia. Subsequently, he did his internal medicine residency at Medical College of Pennsylvania and did a cardiac fellowship at the University of Miami and electrophysiology fellowship at UCLA. And another electrophysiology fellowship there also. He was the first doctor in Orange County to implant one of the newest types of implants, pacemaker, called Micra. He was the first one to implant one here in 2016. Since that time, he's done many more, and he's currently the leading electrophysiology cardiologist in Orange County. And so he today is going to talk to us about atrial fibrillation. There's a lot of new research that's been done on that, a lot of large studies, a lot of new approaches to diagnosis and treatment. So please welcome Dr. Brian Kim.
Thank you for the kind introduction, Dr. Martin. It's my pleasure to be here. I'm an electrophysiologist, so I'm going to answer that question because everybody asks me, what is your specialty? I'm an electrophysiologist. Basically means I'm a heart doctor that deals with irregular heartbeat. So they're plumbers, we'll call them interventional cardiologists. I'm an electrician, so if you have an electrical abnormality such as rhythm disorders or slow heart rate or fast heart rate, I either put a pacemaker, defibrillator, or do procedure like ablation. So sometimes I go and ablate the area to correct the rhythm. Of course, that's only part of my practice. I also treat patients with the medications, and there are several ways to treat irregular heartbeat. So, all in short, basically, I'm a rhythm guy with the electrical problems. So we're gonna have topic is called atrial fibrillation. I'm sure a lot of you, some of you guys are affected by atrial fibrillation. It is predominantly the rhythm disorder affecting Medicare age. So when you're younger, let's say 20s and 30s, atrial fibrillation is very unlikely. But when you hit the Medicare age 65 and beyond, about 6 to 9% of the population will eventually develop atrial fibrillation. So you're not alone, okay? So we'll talk about atrial fibrillation. So during this presentation, I would like to talk about definition, description of atrial fibrillation, and also prevalence. About 5 million Americans are affected by atrial fibrillation. So what causes atrial fibrillation? We'll talk about contributing factors. Hopefully there's some reversible causes that we could eliminate, but there are more permanent causes for atrial fibrillation. And also we'll talk about consequences of atrial fibrillation. What does that do to you? And finally, we'll talk about making diagnosis and approach to treat atrial fibrillation. So atrial fibrillation, once again, is #1 most common rhythm disorder out of all the rhythm disturbances. Again, this affects predominantly older population beyond age 65, Medicare age. In atrial fibrillation is a rhythm disorder that affects the upper chamber of the heart. So rather than having normal sequence between the upper chamber and the lower chamber, upper chamber will basically beat really fast. Oftentimes, it'll be greater than 400 beats per minute. Now, normal sinus rhythm should have a heart rate of about 60 to 80 beats per minute at rest. Of course, it'll go up if you exercise, and it'll go down when you take medication or relax or go to sleep. But 400 beats per minute to 600 beats per minute is too fast. So that's why we call it fibrillation. So let's look at it this way. Upper chamber is supposed to go contraction 1 in every seconds. By doing so, you're going to actually move the blood to the lower chamber so it moves forward. When you're fibrillating, upper chamber is beating at 400, 600 beats per minute. Basically, you're fibrillating. There really is no good contraction. So what happens? Blood in the upper chamber will tend to hang out together a lot longer. Now, if you stay in the same place long, especially in your body, it's never good because everything needs to move forward. When you fibrillate and blood starts to hang out together, they become sticky. When they become sticky, they create blood clot. Now, if the blood clot goes to brain, it's devastating stroke, because that's going to cause a stroke. And that's why patients with atrial fibrillation with enough risk factors should be on blood thinner, and we'll talk about that. So this is a diagram of heart. I'm going to actually go with the normal heartbeat. So everybody has a natural pacemaker. It comes from sinus node in the high upper right atrium. Pacemaker is very simple. Anything that is the fastest in the heart will set the pacemaker. It so happens that in the upper sinus node is usually the fastest. Now, after the sinus node, the next fastest area will be the junctional. So if sinus node fails, you're going to have junctional escape rhythm. If that fails, then you go to tertiary pacemaker, usually in the ventricle. Sinus node will have a heart rate of about, I'll say, 60 to 80 beats per minute at rest. Junctional, 40 to 60 beats per minute. That's still okay, you're not going to die. But if that fails, then you're going to go to ventricular escape rhythm. That's about 20 to 40 beats per minute. I don't think you'll die, but you're going to feel really bad. And that's why you need to go to the hospital and be treated. Oftentimes, these patients will need permanent pacemaker insertion. But anyway, upper chamber sinus node will give you blinking light. So upper chamber will see that electrical activity first through the basically conduction pathways or through propagation through the muscle to the upper chamber. So upper chamber will see the electrical activity. Heart muscle, in a way, is very simple. When they see electrical activity, they contract. So upper chamber will contract first. And through there, you're going to go to what we call specialized cell called AV node. Just make it, it's a relay point between the upper chamber and lower chamber. Normally you have insulation. So upper chamber activity will go to relay point, and this is basically electrical wire. Yes, there is an electrical wire in your heart. One for the right, we call it right bundle. One for the left, we call it left bundle branch block. Left bundle branch. So basically electrical activity will go through the wires and contract. So you have upper chamber, lower chamber, upper chamber. God gave us a really good heart. So that will be the normal way the heart should be contracting. But let's see what happens in atrial fibrillation. You don't really have organized rhythm. Atrial fibrillation, like I said before, will contract around 400 to 600 beats per minute. Now, if the electrical activity translated down to lower chamber, which is a pumping chamber, you're checking pulse. Pulse comes from here, left ventricle. This is the pumping chamber. If your heart rate is at 400 to 600 beats per minute, that's basically ventricular fibrillation. It's not compatible with the life. That's how you die, when you have a ventricular fibrillation. That's a different story. But, like I said, when you have AV node, the God gave us actually protections. AV node is a filtering mechanism. When you're in lower normal heart rate, you'll get a one-to-one conduction. When it starts to become very fast, this AV node becomes lazier, which is good, because you don't want to have all 400, 600 beats per minute going down to the lower chamber, which will be life-threatening. However, this relay point will still conduct fraction of that upper chamber electrical activity to the lower chamber. Oftentimes, your heart rate will still be fast, about 150 beats per minute, which is still too fast when you're at rest. Your heart rate should be, 60, 80, or maybe below 100 beats per minute. If your heart rate is greater than, let's say, 120, 130 beats per minute resting, it's like running a marathon all the time, doing nothing. And your heart could actually go into heart failure. So that's what atrial fibrillation do to you. Oftentimes, you're going to have a fast, rapid heartbeat. Upper chamber will be disorganized, not contracted, blood is not moving forward. Lower chamber, if you oftentimes check your pulse, it's fast, causing symptoms of fatigue, shortness of breath, and angina, chest pain. If you have a coronary artery disease and already compromised blood flow to your heart, you're going to have above symptoms. So, definition first. So, not all atrial fibrillation is same. So, there's always going to be new onset because you are born with atrial fibrillation. There will always be first time. We call it new onset. The recurrent is, as it says, if you have more than one episode of atrial fibrillation, is recurrent. A paroxysmal atrial fibrillation, I call it occasional atrial fibrillation. So usually the beginning stage of atrial fibrillation, meaning you're going to have bouts of atrial fibrillation. You come back to normal rhythm, you go in and out, you don't stay in. Now, unfortunately, atrial fibrillation is progressive disorder. So, start with the atrial fibrillation, paroxysmal, and then later on, you're going to go into persistent stage. So, over time, you're going to have an increase in frequency and duration of atrial fibrillation. And paroxysmal, by definition, for conveniently, if it's less than 7 days, 1 week, we call it paroxysmal AFib. If it's greater than 1 week, we call it persistent AFib. And what's permanent? Well, you're in atrial fibrillation all the time. You progress to basically far end. We do electrical shock to get you out of atrial fib. We use medication, doesn't work. You're in atrial fibrillation permanently. Now, low atrial fibrillation is an interesting concept. So what's low atrial fibrillation? Somebody who's younger than 60, doesn't have any other risk factors, hypertension, heart failure, whatever. Just young, healthier person has an atrial fibrillation. There are people out there with the atrial fibrillation without much of a risk factor. So it affects about 5 million Americans. It is actually age dependent. The prevalence is actually age dependent. When you're younger, it's kind of rare. When you're older, like I said, in your Medicaid age, 6 to 9% of the population will develop atrial fibrillation. And the bad thing is it's expected to grow because, unfortunately, Americans are getting older. Population is getting bigger, there are older people, and therefore there will be more atrial fibrillation. So there are several different types of irregular heartbeat, ventricular fibrillation, tachycardia, sinus syndromes, and on. Out of those, atrial fibrillation. We spend the most money dealing with atrial fibrillation because we have so many people with atrial fibrillation, and hence we're going to have to spend a lot of money. So what's the impact? It's a hemodynamic. I'm going to go over that very frequently. When you're in atrial fibrillation, you don't have synchrony. Upper chamber and lower chamber, they don't work in synchrony. So fast heartbeat, you oftentimes will have fast heartbeat. When your heart is beating fast, they're gonna need more oxygen. They're gonna need more gasoline, I guess, right? So your cars keep on, going faster, you're gonna need more gasoline. So as a heart, they're gonna need more oxygen. So therefore, you're gonna have symptoms like fatigue, shortness of breath, and so on. Like irregular heartbeat, it's not as efficient as regular heartbeat. So this is gross description of the effect of atrial fibrillation. When you have AFib, this is sinus rhythm, patient looks happier. When in atrial fibrillation, you can have symptoms as described before. So what's the outcome of having atrial fibrillation? Your mortality, your likelihood of dying is doubled compared to those people who doesn't have an atrial fibrillation. You have a 5 times likelihood of having stroke compared to those people who doesn't have atrial fibrillation. You're going to be going to the hospital more often than those people who doesn't have AFib. Quality of life is going to be various, but probably not as good. Because when your heart rate is beating too fast, too slow, erratic, you're probably going to have a not good of an exercise tolerance, and you're going to be having more symptoms. You are 3 times likely to develop heart failure. And finally, we spend about $6 billion every year treating atrial fibrillation. So, most important thing is actually down here. So I actually described it before. So atrial fibrillation, it starts with a rare episode. Sometimes you have an atrial fibrillation, you don't know you have it. Or you don't realize you have an atrial fibrillation. But they will increase in frequency and duration. Finally, you have developed symptoms, and oftentimes you go to doctors, and incidentally, the doctor will listen to you and say, wait a minute, your heart rate is not beating regular. So they end up doing an EKG, you get diagnosed with atrial fibrillation. That person is actually lucky. If you had atrial fibrillation and didn't have any symptom, I think that person is in very high risk for stroke. Because whether you have symptomatic atrial fibrillation or asymptomatic atrial fibrillation, your risk for stroke is exactly the same, right? So, unlucky person is who presents to hospital with a stroke as a first presenting symptom, because they didn't know that they had an AFib. They didn't go see a doctor, and they were in AFib, they developed blood clot. Unfortunately, their first presentation was stroke. It may be a little too late, right? But anyway, so you start with the bouts of atrial fibrillation, you're going to have increase in frequency and duration, where you have what we call paroxysmal AFib. Later on, it develops to persistent AFib. You have a longer duration, more frequency, to a point that you actually have permanent atrial fibrillation. So what are the contributing factors for atrial fibrillation? These are the reversible causes that we could do something about it very easily. You have electrolyte abnormality. Let's say you're getting dialyzed, your potassium is oftentimes not right, or sodium is not right, potassium, magnesium not right. If you have a hypokalemia or electrolyte abnormality, it could set atrial fibrillation. Correct electrolytes. That will actually be all you need to do. Now, you could have a pulmonary embolism. It's a blood clot from the leg or whatever that goes to your lung and increase the pressure in the lung, and dilatation happens in the heart and set up atrial fibrillation. Treat blood clot with a blood thinner. Hyperthyroidism, this is one thing that I want to actually stress, or that I actually look for. Anybody with a new onset atrial fibrillation, I always check for thyroid problem. Hyperthyroid could set up atrial fibrillation. Correct that problem, your atrial fibrillation will likely go away. Alcohol, I'm not telling you not to drink, because I drink myself sometimes. But we're talking about heavy drinkers, chronic heavy drinker. If you have, drink a lot, you can actually develop what we call alcohol-induced heart failure. Those patients could develop atrial fibrillation. Oftentimes, if you stop drinking or go down to moderations, your heart function will get better, and so is atrial fibrillation will get better too. The inflammation, this is something that occurs due to heart inflammation. Oftentimes, it's associated with surgery. You get a bypass surgery, valve surgery, you basically cut your muscles and you're gonna have inflammation. It causes atrial fibrillation. Those people who had a bypass surgery, oftentimes they'll be on medication called amiodarone for short duration, because surgeons know that you're gonna develop atrial fibrillation after the surgery. So that AFib, that atrial fibrillation that occurs immediately after the surgery, we don't think that is true AFib, but maybe transient or temporary atrial fibrillation. But there are more permanent, causes for atrial fibrillation. Heart failure, not good. Hypertension, valve disease, or blocked artery, coronary artery disease. These all need to be managed accordingly and avoid these causes. But out of all those, I want to stress that out. It's not the cause for atrial fibrillation. Age is not the cause for atrial fibrillation. However, it is number one associated factor for atrial fibrillation. Like I said, if you're older, let's say 80, you're more likely to have an atrial fibrillation than if you are 20s and 30s. So what causes really atrial fibrillation? So there's something called pathophysiology. It's called fibrosis. Heart muscle, when you're young, is actually nice and just basically all muscles. As you get older, there's got to be insult, either due to hypertension or coronary artery disease and so on. Heart muscle is actually replaced by scar tissue, very small scar tissues. What does that do? That makes it not uniform. It creates a bypass tract because of pathways. And I think that that's basically the pathophysiology underlying cause of atrial fibrillation. So, you need to treat your hypertension, avoid having heart failure. If you have a valve problem, you need to fix it, and so on. So, the most important thing is, as you get older, you're expected to have a more likelihood of having atrial fibrillation. So, this is basically the diagram that shows prevalence of atrial fibrillation in each age group. See here, the Medicaid age, that's where atrial fibrillation occurs a lot more. So how do we evaluate patients with atrial fibrillation? So detections, if you have a symptom, go see a doctor. Sometimes nowadays they have apps, like even Apple phones or whatever, they actually have apps, they tell you they're in AFib. If you feel your heart is beating is irregular, you want to go see a doctor and get an EKG. All right, so EKG is absolutely needed to make a diagnosis. But then again, remember I told you that atrial fibrillation could be paroxysmal. You could be on and off. Unless you go see a doctor when you're in atrial fibrillation, EKG will give you normal rhythm. I'll see you later, right? But if you have the symptom, talk to your doctor or ask for cardiology consult. I have palpitation, not today, but I had it yesterday. I had it like a week ago. You need to have something called event monitor, something that monitors your heart rate for longer duration, not that EKG, because EKG only detects you for 6 seconds at that point in time. If you don't have symptom at the time, you're not gonna have that diagnosis. So there are other modality to detect atrial fibrillation depending on frequency of your atrial fibrillation. So Holter monitor is usually for 24 to 48 hours. If you have like once every day, this will be good. But what if you have like, event once every week or so? Then we have an extended event monitor for 2 to 4 weeks. We have a patch that you wear. You could actually take a shower with it. They still detect what's going on. But what if you have an event monitor? What if you have an event that occurs maybe once in a blue moon, once in every 2-3 months? Obviously, this is not going to be adequate. So you have what we call loop recorder implant. It's nowadays a very small chip that we actually literally insert under the skin. Battery lasts for 3-4 years, and it's hooked up to your telephone line. And if there's an alert, the doctors get alerted and will call you and say, Ms. Jones, you had atrial fibrillation. Why don't you come over? I think you need to start taking some medication. Now, the other thing that I want to tell you is that I'm sure some of you guys might have a device, pacemaker or defibrillator. I run very busy device clinics. I have a lot of patients who comes into my clinic to have the device checked. Pacemaker and defibrillator is a very sensitive and very specific in detecting atrial fibrillation. You may not have known that you had an atrial fibrillation, but this pacemaker will tell you that you had it. So I do pacemaker check, routine check, patient had no symptoms whatsoever, came in, pacemaker check, you had an atrial fibrillation. So these patients again detected, fortunately because of the pacemaker, and they get started on appropriate blood thinner. And I always look very carefully. I always tell my technicians to look for atrial fibrillation on pacemaker interrogation. If they had the detection of atrial fibrillation and not being treated, especially with a blood thinner, they get started on blood thinner immediately to prevent a stroke. So basically, what do I do when I see patients with atrial fibrillation? I want to relieve the symptoms. Oftentimes, you're going to have a really fast heartbeat. They don't feel good. There are medications like beta blocker, metoprolol. I give them medication to bring the heart rate down, relieve the symptom. Detailed history is very important because just because you don't have an HFib today, it doesn't mean that you didn't have it. Like I said, you're going to have on and off. If you have one every week, I'm going to probably order event monitor to detect that. If you have one in a few months, maybe loop recorder is the right thing to do. Now, the most important thing that I concentrate on when I see patients is a stroke risk. I don't want to have a stroke. I don't want my patient to have a stroke. So this is actually what we call CHAS-VAS score. So it's basically a scoring system to look at what's your likelihood of having a stroke. Not everybody with the atrial fibrillation has the same risk for stroke. So there are contributing factors. We basically give them scores and you add them all up, and I give you rough estimate as to what's your risk of having a stroke every year. I'll come back to that later. But that's actually one thing that I always look at. If you see a cardiologist, they'll probably always talk about CHAS-VAS score, CHAS-VAS score. That's it. So to detect atrial fibrillation, you want to get EKG. And also, I look at some of the blood works. One thing that I concentrate on is thyroid stimulation, thyroid abnormality. If you have hyperthyroid, you need to be treated. If your electrolyte is abnormal, you need to be treated. If you have anemia, CBC, you might have bleeding or loss of blood that you don't know about, needs to be treated. Echocardiogram is ultrasound of your heart. Basically look at your heart function. You want to see heart function, whether it's squeezing well. We're going to look at the valve function, make sure there's no valve restrictions. I also like to look at the dimensions, the size of each chambers. If left atrium is bigger, you're more likely to have an atrial fibrillation because that's one risk factor to develop atrial fibrillation. Also stress tests, I'm sure many of you guys have done stress tests. We look at stress tests, make sure you don't have any blocked artery as a contributing factor for atrial fibrillation. Furthermore, these patients often need medical treatment like anti-arrhythmic medication, like namely flecainide class 1C, should not be given in patients with a blocked artery. So if I want to have more armament, I want to treat patients with medication, I want to make sure that I have safe medication to give to my patient. So stress test will be ordered when you see a doctor. So let's talk about blood thinner. I'm sure you guys will know about blood thinner. I told you that people with atrial fibrillation has 5 times likely to develop atrial fibrillation, and therefore need to be treated with a blood thinner. So these are the medications. We used to have a warfarin, Coumadin. We don't use that as often, but I'm sure there are some people still using warfarin. We have a newer medications, Xarelto, Eliquis, Avesa, and Pradaxa. These are the medications that you could take it either once a day or twice a day. You don't need to have any blood work done. You could eat all the green vegetable you want, or you can't do that with warfarin. The problem with this medication is very expensive. All right, so this is actually a CT scan of the brain. So this dark area, stroke. Okay? Now, I told you that people with atrial fibrillation has a 5 times likely to develop stroke. And oftentimes, when you have a stroke from atrial fibrillation, it's much more debilitating because it involves larger area of the brain. Why? Because when you have thrombotic stroke, which actually occurs from the small vessels, you're going to affect only that area, which is a smaller area. When you have blood clot coming from the heart, it's oftentimes a large blood clot blown up, basically blocking really big artery, affecting big chunk of the brain, and therefore you're going to have a much more severe stroke coming from atrial fibrillation. So anticoagulation, the blood thinner that I mentioned before, will reduce stroke risk by 2/3. Antiplatelet, aspirin, will reduce about 1/5. So anticoagulation has reduced the risk of having a stroke, obviously. So this is a CHA2DS2-VASc score. So this actually stands for something. So CHA2DS2-VASc, right? C stands for congestive heart failure, score 1. Hypertension, age greater than 75, you double the risk, so you get 2 points. Diabetes, stroke, gets 2. So obviously somebody with a stroke has much higher risk for recurrent stroke. Vascular disease, heart attack, or peripheral artery disease, you get scale 1. If you have age between 65 to 74, you get 1 instead of 2. And then second category, if you're female, unfortunately, you add another risk factor. So for some reason, if you're female, you're likely to develop stroke than male counterpart. So basically, you add it all up, the maximum score that you could have is 9. Right? I haven't actually seen anybody has 9 yet, but. So just look at this. This is actually that. So if you have 0, your relative risk for stroke every year is 0. If you have just 1, your chance of having a stroke is 1.3% a year. It goes up 2.2, and basically all the way to 9. If you have stroke 9, your likelihood of having stroke is 15 to 20% every year. So you add it all up. So what do you do with these people? Basically, we see a patients, we go through all the risk factors, score them, and then if you have, in my practice, or the current guideline is if you have 2 or more, automatically gets blood thinner. So this is it. CHA score 0. No anticoagulation is needed because 0%, right? If you have 1, you have a choice. Basically, none, aspirin, or blood thinner. 2, most of the cardiologists will put you on blood thinner, either warfarin or any one of those new medications that I mentioned before. So warfarin, we use that warfarin a long period of time. I'm sure there's some still taking warfarin. The warfarin is actually really very painful to follow. It's cheap because most of the insurance will cover it, but you have to be diligent because you have to go out and get your blood drawn every so often, at least once a month. You are restricted from anything that has something to do with the vitamin K thing, that is green vegetable. If you have a lot more salad this month, your level's gonna go down. And you're gonna be less protected from stroke. If you had less green vegetable, or you had antibiotics or whatnot, your level is gonna all of a sudden go up. And there's a basically art to that. We follow international normalization radio, we call it RNR. So when you take Coumadin, we draw blood, make sure level falls in between 2 to 3. Because, this is it, when you fall below 2, your stroke rate is high. Beyond 2, your stroke rate is there's not much of a benefit whether you have 2 or 7. However, when you go above 3, your bleeding risk goes really up. So that's why we have a very narrow therapeutic window, 2 to 3. It's difficult to achieve. So finally, we're going to talk about treatment options. I'm sure you guys are very interested about treatment options. How do we treat atrial fibrillation? I usually give 3 options to my patients. Number 1, rate control. What's rate control? You're going to be an atrial fib, but we're going to control your pulse rate so you feel better. All these patients, if you have appropriate CHA2DS score 2 or more, they all need to be blood thinner. But beyond that, these are the treatment options. Rhythm control. I am trying to keep the patient in normal rhythm, either by means of medications or cardioversion. There will be second approach. Third approach is usually basically secondary but invasive options. Ablation. Pacemaker with the avial ablation, we'll talk about that. And a surgical ablation. We don't really offer surgical ablation, but it is actually a good thing to do if you have atrial fibrillation and basically need to go to the surgery anyway. Let's say you have bypass surgery pending. You have an AFib. They'll do bypass and do the surgical ablation at the same time. You need to have a valve surgery. They'll do the surgical atrial fibrillation ablation plus the valve surgery, because they're there anyway. So other than that, I don't recommend surgical ablation, but these are treatment options. So people ask me, like, doctor, what do you think I should do? Should I go rate control or should I go rhythm control? It's hard to say. So it depends on who you ask. Okay? So there's a study called AFFIRM trial. This was done in 2002 when I was a fellow. So they looked at stroke rate and the death rate. They followed for 5 years. So what do you think the answer was? About the same. So, okay, so whether you try to go into normal rhythm with the medication versus whether you stay in atrial fibrillation but take blood thinner and treat with a beta blocker, they follow. Stroke rate and death rate were the same. So there's a debate, depending on who you ask. Okay? You go to so-called conservative cardiologists, they always look at AFFIRM trial. It's the same thing. Why bother, right? Just stay with the rate control. You go to somewhat more aggressive person that quote beyond 5 years. Beyond 5 years. They only follow for 5 years. So what happened beyond 5 years? Do we have any data? There's some data that atrial fibrillation is likely to cause heart failure. Heart failure has been linked to decreased survival rate. So it depends who you ask. Anyway, so let's say you do the rate control, you still don't have good, stamina, you're still short of breath, your pulse rate is good. We did what we can with rate control, yet you're not feeling good because upper chamber and the lower chamber are not in synchrony. In an elderly person, 30% of the efficiency comes from synchrony alone. So you're going to lose about 30% of the efficiency just by being in atrial fibrillation. So rate control may be not enough. In this particular individual population, restoration of sinus rhythm is desirable or is actually should be done. So these are the basically medications that we use for rate control. If the rate control is not adequate, then you go to the next level, rhythm control. So to maintain a normal rhythm, you're not going to get it by doing nothing. You're going to need to basically work on it, and there are medications like anti-arrhythmic medication. These are the basically most common medications that we use. We use flecainide and Moltec now, and amiodarone. These are the medications that will likely keep you in normal rhythm. But let's talk about side effect of this medication. All these medications, unlike rate control like beta blocker, digoxin, and calcium channel blocker, you might have some side effect, but if you stop taking the medication, it washes out of you. But some of these medications all possibly could cause a life-threatening irregular heartbeat. Irregular heartbeat is much worse than atrial fibrillation that you want to treat. We talked about flecainide. This is one of the medications I use because it's cheap and is out there. Flecainide. However, there's a prior study called CAST. Well, basically what it means is that if you're taking this flecainide type of medication in patients with blocked artery, they die. Higher rate. Because it causes much worse irregular heartbeat called ventricular fibrillation coming from the lower chamber. Lower chamber is much more important chamber, as far as the rhythm concerned. So you try to treat atrial fibrillation, which is not life-threatening, but you end up creating life-threatening irregular heartbeats. So that's why we have to do a stress test. Amiodarone. Some people like amiodarone. It's been there for a long period of time. In fact, it actually works much better than the other anti-arrhythmic medication. I don't use it. You know why? Because I almost lost a patient because of the side effect from amiodarone. I use it if I have to. Amiodarone has a lot of side effects. Your thyroid abnormality, if you actually go out on sunny day without protection, you're going to be actually, purple. You're going to turn into purple. You have liver failure. You're going to have a point fibrosis, which you can't breathe. I'm not saying everybody, but if you develop side effect from amiodarone, oftentimes it could be life-threatening. Like I said, when we treat patients for atrial fibrillation, it isn't so much of the efficacy. I think it is a safe profile that actually comes into mind first. Am I going to do any harm treating this patient with anti-arrhythmic medication? Sotalol is another medication that many cardiologists use, but it causes what we call QT prolongation and causes ventricular fibrillation. Should not be used in patients with a kidney problem because it's clear through the kidney. And if you can't clear through the kidney, you're going to have a lot more sotalol in your blood system, and you're going to have what we call QT prolongation, which causes a ventricular fibrillation, which is life-threatening arrhythmia. So, like I said, there are many medications out there, but it's not without the risk. So you have to always weigh the risk and benefit, and the safety profile is the most important factors to consider when you try that on patients. So this is basically a diagram. So basically, I'm just going to go briefly. You have an atrial fibrillation. You don't have any other structural heart disease. These medications are fine. So amiodarone and dofetilide are the one that has more side effects, so they'll recommend as a first-line therapy. If you try medication that fail, I think that you'll be a good candidate for catheter ablation. And you have hypertension with the thickened heart muscles. These are the medication and so on. But talk about that later. So how effective is anti-arrhythmic medication? Okay, so I use it. You want to use it, make sure that it works, right? So this is likelihood of maintaining sinus rhythm with the medication beyond 6 months. Quinidine, disopyramide, propafenone, flecainide, sotalol, about 50%. So even though you use medication, the likelihood of maintaining sinus rhythm beyond 6 months, 50%. Amiodarone is more effective compared to other medications, but has a lot more side effect, so you have to take it into account. But let's look at it. What happens if you don't take any medication? Right here, no drug, 30%. So even without any medication, your chance of maintaining sinus rhythm, 30%. So by taking medication, you go from 30% to 50%. It's not 100%, right? So electrocardioversion is basically relatively safe procedure to restore normal rhythm. You come to the hospital, we have an anesthesiologist to put you to sleep for 30 seconds to a minute with a propofol. That's the medication that Michael Jackson got. But it was administered by cardiologists, no anesthesiologists. At St. Jude Hospital, we have anesthesiologists to maintain airway, make sure the patient goes out alive. Anyway, so we put the patient to sleep for 30 seconds to a minute with shock, oftentimes with a high energy. Sinus rhythm is likely to be restored. Most likely you're going to go back to normal rhythm, at least at that point in time. However, relapse is very high. In my opinion, it's a matter of when, not if. When are you going to go back to atrial fibrillation? Maybe today, maybe tomorrow, or maybe a couple years down the road. If you're in normal rhythm for a few years, you're lucky, because most of the atrial fibrillation will come back. All right, so there's an invasive option, ablation. So let's say you tried the medication, didn't work, and you don't really get the relief. And ablation, this is my subjective point, and oftentimes the electrophysiologists will tell you, when you do an ablation, your success rate will be about 60 to 80% maintaining sinus rhythm. I think that's about fair observation. But depending on what stage of atrial fibrillation you're in, if you're at earlier stage, your success will be high. If you're later, like permanent AFib, you're going to need more than one ablation. You're not going to get normal rhythm with just ablation. I can pretty much tell you because I treat patients like that. So, like I said, we have 5 million Americans affected by atrial fibrillation. Out of those, about 3 million Americans are symptomatic. And when you are treated with a medication, about half, 1.5 million Americans are basically symptomatic. It's drug failure. Like I said, medication only works about 50% of the time, which brings about 1.5 million people have drug failure and they're symptomatic. And they are a good candidate for ablation, but I think they will only treat probably 10% of that population. So, indication, if you have an AFib, drug didn't work, then you'll be a candidate for atrial fibrillation. So, drug therapy versus ablation, what's better, right? Obviously, current guideline is try medication. If the medication doesn't work, then you'll be a candidate. I tell you, if the medication doesn't work, the other medication is unlikely that's going to do better, unless you try amiodarone, but then you're going to actually run the risk of developing other risk factors, like complications like liver problems and so on. So this is actually new data. So if you had an atrial fibrillation, right, and there's a drug, right, your likelihood of staying in normal rhythm is much higher if you had an ablation. Well, this is basically comparing two different types of ablation. There's cryoablation, which is a freezing technique, versus RF ablation, which is burning technique. At St. Jude Hospital, we offer both. And cryoablation is only indicated for earlier stage of atrial fibrillation, where you go in and out, because target is basically confined to pulmonary vein. Cryoablation could do just as well as the radiofrequency ablation. But if you go beyond earlier stage, I think, in my practice, I do RF ablation because you're going to need a lot of extensive ablation. So these are comparison between, drug therapy and ablation. After the ablation, your risk of stroke is lower. Your mortality is also lower after the ablation. Your likelihood of maintaining normal rhythm after the ablation is higher in ablation group versus drug therapy. So let's go briefly about the techniques. So we have a cryoablation and RF ablation. We've been doing this burning technique ablation So there's a catheter, we basically by point kind of drag it around. And this cryoablation is easier. A lot of the electrophysiologists nowadays love to do cryoablation because it doesn't require, I'll say, it requires less skills, like, in a way. It's faster. So basically, blew it up, shove it in, freeze here, create a barrier. So basically, this RF ablation burning technique, do it one by one. This one is cryoablation. You shove it in, basically. The surface here that you touch will be damaged intentionally and create a scar, so it creates a barrier. So there's paroxysmal and permanent. Paroxysmal is earlier stage. If you were to do an ablation, you want to do it here, not there, because that's going to require a lot more ablation and success rate is not that high. So I see a lot of patients who have been tried multiple medication. So cardiologist told the patient, so patient had earlier stage, he had a bouts of atrial fibrillation, they tried flecainide, works fairly well for the first stage, and later on patient has relapse. They go to other medication, higher medication, and finally they try 3-4 antiarrhythmia medication. In the meantime, patient's atrial fibrillation has progressed to heart and permanent AFib, and the patient was referred to me because patient is symptomatic. I wish that patient came earlier. Okay? If you follow the current guidelines, just try one medication. You know what? Please send it to me. Because you're not really doing your patient a favor by holding on to your patient and try multiple medications, because that's going to fail. And when they fail, the patient's going to be in much worse condition because you want to restore normal rhythm. Paroxysmal has earlier stage has a lot higher success rate than the later state. So paroxysmal AFib is very easy. Just isolate the vein. Oftentimes we could do it in less than an hour and a half. Very confined. Permanent AFib, oftentimes you're going to need a lot more ablation. You're going to need to burn a big part of the left atrium in addition to the pulmonary vein. So complications are these, usually about 2-3% depending on who's doing it. It's actually very operator dependent. If you've done a lot of AFib, you're going to be better because it's actually, it takes a certain know-how. If you haven't done enough, it's going to take longer. So these are the guidelines. So if you try one antiarrhythmic medication, hasn't failed, now you're an acceptable candidate for atrial fibrillation. So besides atrial fibrillation, because you know what, you don't want to go through that, because AFib, like I said, success rate is about 60 to 80% when you have paroxysmal. When you have permanent AFib, your success rate is not going to be high, and you're going to need multiple ablation. In the meantime, you don't want to go through all that cascade several months down the road. Your heart rate is out of control because medication doesn't work, and you really need a relief right now. Cardioversion didn't work. The other option is pacemaker with AV nodal ablation. It's actually a simple concept. Pacemaker is inserted in anticipation for a slow heart rate, which you're going to create by doing AV nodal ablation. So remember I told you that this is a relay point between the upper chamber and lower chamber. Upper chamber is beating at 400 beats per minute. A lot of the electrical activity is going down to the lower chamber. I'm going to cut that right there. It's very simple. You put one electrical wire, put the catheter, cauterize. All of a sudden your heart rate, you know what it's going to be? 20, 30 beats per minute. Remember? This is subsidiary tertiary pacemaker. The inherent heart rate will be about 20 to 40 beats per minute. From your heart rate of 150 beats per minute, you're going to go immediately into heart rate of 30 beats per minute. But we don't want to do that without putting a pacemaker. So we do two things at the same time. We put the pacemaker and go and burn it. So all of a sudden your heart rate is 20, but because we put a pacemaker, we could set the rate whatever we want. So your heart rate is always regular, and you don't need a medication to control your heart rate, and it's highly effective. Success rate is 95% or better. But why don't we do this all the time, right? But there's always pros and cons, right? So pros, highly effective, you're gonna have immediate relief and you can stop the medication. I mean, the medication to control your heart rate, you can stop it immediately. What's the cons? Upper chamber is still fibrillating. You check your pulse, wow, I have a normal heartbeat. I'm gonna stop medication. No, please don't. Because upper chamber is still fibrillating and your risk for a stroke is exactly the same. So your upper chamber is still fibrillating, you still need to take blood thinner. And if your symptoms are secondary to dysynchrony, your relief is not going to come. Even though your heart rate is better, you're still going to lose about 30%, I guess. You still don't have synchrony. You're still an AFib, you still need to take blood thinner. All right, so I think we talked about all the options of treatment. There's one thing that I actually want to talk about is Watchman device. It's a new technique. I don't do it, but I have a partner who could do it. What's Watchman device? It's an alternative to blood thinner. Now, you need to take blood thinner to prevent stroke. But let's say you really can't tolerate medication, blood thinner. Good example would be somebody who falls frequently. When you're on blood, you fall, you're gonna have a bleed. Let's say you have a bleed in the brain, you're on a blood thinner, not good, right? You have gastrointestinal bleed. Your stomach had ulcer and you had a bleeding episode, you lost a lot of blood. Maybe not a good candidate to be on blood thinner forever. So this is the new technology. Watchman. It looks like an umbrella. Heart has a little pouch, left atrium. This is usually where the blood clot will form. So what we do, we go through the groin, go over there, and deploy that umbrella. So block that pouch. And later on, after about a month or two, it basically get replaced with your heart tissue. So even with the Watchman device, you still have to take blood thinner warfarin for 45 days. That's the current guideline. You need to be on a blood thinner. So if you could take blood thinner for about 1.5 months, you'll be a candidate pending that you have a justifiable reason to have Watchman. So that's the recommendation. So we talked about all the we basically touched all the aspects of atrial fibrillation. Atrial fibrillation is a huge problem. It affects about 6 million Americans, and it costs a lot of money. There's rate control, rhythm control, ablation, pacemaker. All these are possible treatment options. I think that's it. Thank you. I'll take questions if you have. Yes, go ahead.
In the list of medications for rate, you didn't mention Norpace.
Norpace is actually an anti-arrhythmic medication. So it's one of the categories that belong to rhythm control to keep you in normal rhythm. So the question was, among the rate control, Norpace was not mentioned. Norpace, however, is actually one of the anti-arrhythmic medication. It's called rhythm control. Second, basically try to keep you in normal rhythm. Now, if you're taking that medication and you're still having atrial fibrillation, you have a drug failure. So if that's the case, I'm not saying that it failed on you or whatever. If you're taking Norpace and you're still having atrial fibrillation, you might as well go back to your doctor and say, I want to take other medication. It's not working. So you might as well go beta blocker or something else.
But the problem is the insurance isn't going to pay for it anymore.
Norpace?
Yeah.
Yeah, Norpace is actually not used often. Okay, so nowadays we have other anti-arrhythmic medications. Does it work for you?
Yeah, it's working.
Okay, good.
That's what's upsetting, because they said, well, people over 65 shouldn't take it.
Well, there's pros and cons, and I think the Norpace we're not really using that much. So that may be, I'm sure some pharmacy will still have Norpace. No? Yeah. But we don't use that much nowadays. Okay. Okay. All right, the question was tamponade. I think I actually had that as one of the complications. All right, so heart is surrounded by a small sac. to lubricate the heart, function. Normally, there's no space, very narrow space. However, if you start collecting,
Pericardium, are you talking about?
that's correct. Pericardium is a sac
Yeah.
that covers the heart. Normally, there's a very little space. However, if you start collecting fluid, heart has to contract, expand and contract. But let's say now you have pressures pushing down on your heart, because heart cannot contract because there's a fluid surrounding the heart. This could oftentimes happen in patients with dialysis patients. They develop fluid around it, or acutely during the procedure, if you start bleeding. Let's say I do an ablation, and unfortunately, God forbid, if I perforated the heart, heart's gonna leak blood. The blood has no space to go. It's a pericardium. You're gonna have acute, very fast accumulation of the fluid around the heart sac. The heart cannot contract. It's called tamponade. Now, we need to put a needle and drain it right away. Otherwise, the patient could have serious consequences. Yeah, there's a question. Yes, go ahead.
Given a patient that has permanent AFib and is facing general anesthesia surgery, but has been well controlled on Coumadin for 19 years,
Okay.
when would you recommend stopping the Coumadin before surgery? What period of
I
time?
see. Well, warfarin is actually wearing off in about 3 days. Surgeons are more conservative. They want to hold Coumadin forever before the surgery, but no way. Then you're going to have actually higher risk of developing blood clot and having a stroke. Oftentimes, when you stop Coumadin, you will be bridged. It's called Lovenox. It's basically blood thinner injections. So while your Coumadin goes down, because Coumadin takes a longer time to, wear off and start. In the meantime, as soon as you stop Coumadin, there's a Lovenox injection that we bridge, and you get it until the day before the surgery, and you get the surgery, and immediately you start taking Coumadin so that there's no gap of blood thinners. Does that answer your question?
Yes, thank you.
Okay. All right, the gentleman over there.
Could you say a word about the effectiveness of Tekicin versus amiodarone?
Wow, that's actually very highly technical, but I'm glad you asked that question. So, the effectiveness between Tekicin, which is dofetilide, versus amiodarone. I wish I could go back. It's like actually, so Tekicin is another medication, class 3, is a potassium channel blocker, just like amiodarone. Now, they're all about the same. I think the amiodarone still is more effective than in controlling normal rhythm compared to other antiarrhythmic medication. Now, dofetilide is cleared to the kidney. Amiodarone is degraded through the liver. Now, when you're starting dofetilide, one of the concern is to develop what we call QT prolongation and having torsi, which is ventricular fibrillation and sudden cardiac death. To do so, you come to the hospital, you stay in the hospital for 2-3 days. When you start, you check the electrocardiogram. After the first dose, you check another electrocardiogram, you check electrocardiogram. It's a tedious process. So I don't know if anybody uses dofetilide, some cardiologists do, but you need to come to the hospital for 2-3 day admissions when you start the dofetilide. To answer your question, I think it needs to be individualized. Now, if you have a heart failure, only medication that is actually approved, antiarrhythmic medication that is approved for heart failure patients, either dofetilide or amiodarone. So it's basically personal choice, I think.
But is there less side effects to it?
But like I said, dofetilide, if your kidney function is fine and measured closely, I think that your side effect, long-term other side effect is less. Amiodarone, on the other hand, if you use it for chronically, I think they are actually high likely, in my opinion, high likelihood of developing side effect. Your thyroid will be gone. So when you take amiodarone, you have to do a bunch of tests. First of all, you have to have a chest x-ray, you have to have a thyroid function test, you have to go see an ophthalmologist because you could have a deposit in your cornea and you could actually lose vision. You have to have a chest x-ray and a pulmonary function test. Make sure your oxygen, moving back and forth needs to be normal. So amiodarone is very cumbersome. I'm not saying that everybody will develop side effect from amiodarone, but I don't use it. I almost lost a patient. This is my personal experience. I think that you really need to have a closer follow-up, and when the patient develop side effect from amiodarone, oftentimes it's not pretty. All right, sir, go ahead.
Doctor, if a patient is on Pradaxa, do they
Yes.
also need baby aspirin?
No, actually, to answer your question, yes and no. So, no, that's yes and no. The reason is if you're taking Pradaxa which is for atrial fibrillation to prevent stroke, yes, then you don't need an aspirin. But oftentimes, patients with atrial fibrillation also have blocked artery, coronary artery disease. People had stent placed in the past. There's a distinction between aspirin, which is antiplatelet, and Pradaxa, which is factor 10A, which is anticoagulant. They work for two different reasons. So if you have a blocked artery and a stent, Pradaxa is not going to prevent you or protect you. You need aspirin. So if you're taking aspirin, that's probably for a different reason. Yes, I have patients taking aspirin and Pradaxa. They're for different reasons.
Thank you, doctor.
You're welcome. Yes, ma'am.
What are your thoughts on atenolol to control rate?
So, yes, so atenolol is a beta blocker. It's a once-a-day medication, although it should be, I think, really twice a day. Atenolol is a beta blocker. It doesn't kill you. It's a good medication. You should be, treated the patients with coronary artery disease. Atenolol is good. Atenolol is purely for rate control. It's not going to prevent you from going into atrial fibrillation. So if you've chosen to basically live with the atrial fibrillation, but rather control heart rate, atenolol is great if it works well. But it's personal choice. If you decide to go rate control versus rhythm control, like I said, it depends on who you ask. And atenolol has less side effect. So. Yes, sir.
You mentioned the anti-platelet therapy.
That's correct.
Could you explain what that is?
Okay, so blood has a lot of things. You think that blood is just red stuff. There's a bunch of stuff inside. Okay, there's a coagulation, and there's a platelet which basically creates a plaque. So there's two separate factors that causes a blood clot. Anticoagulates through the cascade. So warfarin and basic medication is Xarelto and things like that. It works on factor creating a clot. Antiplatelet is basically more of a plug. It's a platelet. So a platelet basically aggregate, create a plug. So if you have a stent or coronary artery disease, you need to be on antiplatelet. Namely, aspirin and Plavix. Those are the two medications that you need to take. If you get a stent, you need to be on Plavix. Pradaxa, like this gentleman said, Pradaxa will not prevent you from re-occluding the stent. So you take an antiplatelet, which is aspirin and Plavix. Now, if you have an atrial fibrillation, you don't want to develop a blood clot in your heart, you need to take anticoagulant, warfarin, Pradaxa, Eliquis. So they're completely different, in a way, blood thinner therapy. I hope that answered the questions. Yeah, sure. Any other? Yes, ma'am.
If you take one of the newer blood thinners,
Yes.
not Coumadin, but Eliquis or
Yes.
Xarelto, and you need to have surgery,
Yes.
is your risk of stroke then higher because you have to stop taking it, or how does that work?
The question was, instead of the warfarin, we have a newer anticoagulant like Eliquis, Xarelto, or so on. If you need to go to surgery, you need to stop the medication. Do I need to stop the medication? And what's my risk for stroke? That's an excellent question. Yes, for surgery, depending on what surgery you're going to have, surgeon's not going to do it if you have a blood thinner on board. For example, you're doing a like spinal surgery, the bleed is devastating. You need to stop blood thinner, oftentimes 3 days before the surgery. I mean, I do pacemaker even with the blood thinner on, but if you're doing something really extensive surgery like liver surgery or general surgery, oftentimes surgeons will probably want you to stop blood thinner for 3 days before the surgery. Now, what do you do when you actually stop blood thinner? That's a good question because there was some study that if you stop the blood thinner like Eliquis, you have a immediate higher risk for blood clot and causing a stroke. Unfortunately, when you actually really worry about it, they also basically tells you not to use heparin, but if I think the patient has a very high risk for stroke, I either do the surgery. In my case, I do pacemaker with the blood thinner on board, or ablation with the blood thinner on board. If not, I basically treat immediate medication like heparin or Lovenox as a bridge therapy before the surgery. Hi, there's a gentleman right there.
What is the rate of relapse for ablation?
So, yeah, I think that, it's a good question. The question was just, what's the relapse of atrial fibrillation after ablation, is that correct? All right, so I just showed you that, right there, let me see. All right, so that's basically the relapse. After the ablation, your likelihood of maintaining sinus rhythm in 36 months, it's like 90%. Without it, far less. But I think that is oversimplification. It depends on which patient you do an ablation. As I said before, earlier stage atrial fibrillation has much higher success rate. So if you actually found earlier stage, really earlier stage, pulmonary alone maybe will achieve that. Now if you had permanent, far end, permanent atrial fibrillation, you do one ablation, forget it, they're lying. They're not gonna have normal rhythm with this high rate. So it depends on which patient you're doing it. I think that this is based on paroxysmal AFib, which is earlier stage. If you're later stage, you're gonna need more than one ablation, and the success rate with one ablation alone is not high. Okay, I think that is. Well, thank you very much for inviting me. I'd like to come back again. Thank you.